Thank you very much. Can I have my slides? Okay, they're there. So I already told the Mosaic restaurant not to get anyone inside unless I finish my talk. So we'll go to a nice dinner after this talk. So I'm going to talk about STAMP. I mean, this looks like STAMP means either like step on it or stamp the CML unmet needs, just basically specifically targeting Abelson marital pocket. This is basically a new drug that has come into clinical practice now, and we'll discuss about this. But first, let me just present some of the. So these are my disclosure information. So what's the current status? So the current status, there are 6 TKIs that are currently in clinical practice approved. There is the first generation, everybody knows imatinib, and there are 4 of them in the second generation. The third generations are is like ponatinib, and of course this new drug that is asciminib. Okay. So there is a high response rate from almost all the tyrosine kinase inhibitors as a front line therapy, which are approved like imatinib, and the second generation. So almost all of them are approved as a frontline therapy. TFR, treatment-free remission, is a standard practice now, and a lot of patients did no more the trials. It is considered to be one of the options for patients who go into deep and complete molecular response over 4 to 6 years, depending on what therapy you use. And then, of course, when you have the overall survival is the goal, then one has to consider the treatment value and the cost benefit. So that's one of the reasons that people use the first generation versus second generation. And then, of course, in the near normal life expectancy, what do you expect for the treatment options? So the future perspectives come into play when you have unmet needs in CML. And what are the unmet needs? Okay. So revisiting third line therapy in case of failure of 2 lines of therapy. A lot of patients that go through the first line therapy when they fail, as you know that once they get onto the second line therapy or a second generation, or even if you use the first generation in the later on, the time period that remains there is short. So you don't have much time. Like once you go beyond second line therapy, using another second line therapy is going to give you remission for a shorter period of time. And utilization, as I said, to achieve specific goals. We'll go through the case presentation, and I would like, if in case I could not get into the voting system for this thing, but we'll do a case presentations and we'll go to the main talk. So this is a first case, which is 34-year-old female, January 2012, diagnosis chronic myeloid leukemia. Patient develops severe immune hepatitis, clearly related to imatinib, responded to discontinuation of imatinib, and the liver functions resolved, went up to thousands of ALT and AST, switched to dasatinib. She remained on dasatinib from 2012 to 2017, generally fairly well, responded with deep molecular response and undetectable minimal residual disease or minimal detection of BCR-ABL, but she developed severe headaches in 2017. So all workup was negative for any other causative factor, even to low doses of dasatinib. I came down to 50 milligram every other day, but she continued to have grade 3 headaches. Then the patient was switched to nilotinib at that time. So from 2018 to 2023, for 5 years, she used nilotinib, but again developed headaches, and lately has been admitted to emergency room, came a few times with severe headaches. Again, all workup, including MRIs and all these things, were negative for this patient. And I did try stopping the drug, and the patient did have resolution completely after discontinuation. So this is clearly related to the use of the tyrosine kinase inhibitor. So what should be the aim of the next line of therapy? Is the resolution and avoiding the recurrence of headaches or the side effects, side effect profile of the next therapy. What do you select? Duration, durability, and depth of response. whatever you use or whatever you select has to be the drug that should still be able to give you good duration and durability and the depth of response. And of course, you need an improved progression-free survival and a quality of life also. So what should be the next choice of therapy? I've listed bosutinib, ponatinib, asciminib, other agents, stem cell transplant. Anybody would like to raise hands for the first one, or the second one, or the third one? Nobody wants to raise their hands. Other agents, stem cell transplant. So we'll talk about this thing. So when you look at the headaches, it's almost all TKIs have headaches, but apparently some of them have less as compared to others, although it's not listed, but one of the most, the strongest one with the headaches is actually dasatinib. And then nilotinib and bosutinib also have is ponatinib, again 43%. Apparently asciminib is less associated with headaches. Okay. In any case, I selected asciminib for that patient and I applied for the drug, and the patient is going to start very soon on this one. This is case number 2. This patient was intolerant resistant to 3 TKIs. 47-year-old female with chronic myeloid leukemia, diagnosed 2011. She was started on imatinib. She had an optimal response with major molecular response within 12 months, but continued to have nausea and vomiting along with lower abdominal pain, unable to tolerate. It was almost like an irritable bowel syndrome. She could not tolerate the drugs. So imatinib, labeled as imatinib intolerant 2012, switched to dasatinib. Again, maintained a major molecular response, but continued to have the same symptoms to the extent that she was unable to tolerate, and this patient was dasatinib intolerant. Then was switched to, in 2013, to nilotinib. Achieved deep molecular response of more than 4 log reduction with complete molecular response between 2014 and 17. And then she lost the MMR. Now, sometime when people lose MMR, doesn't mean that you have to change immediately. You need to look at if they remain in complete cytogenetic response or not. But she continued to have an increase in the BCR-ABL despite a good compliance with the medication. So she was labeled as nilotinib resistant 2019. At that time, and there was no other TKI that was available in the institution. So what would be your choice? Although bosutinib and ponatinib was not available, was not started, other agents or stem cell transplant, would somebody take this patient to a transplant at that time? It is an indication. When you look at the NCCN guidelines, 3-line failure is an indication for transplant. But there was a clinical trial that was available. This is known as Assemble trial, and we were part of this international phase 3 trial. Before she went to the trial, there was BCR-ABL was 4.9. There was no additional chromosomal abnormalities, and there was no ABL kinase domain mutation was detected. This patient was randomized to asciminib. 40 milligram BID was started after randomization, and BCR-ABL at the time of randomization was 4.9, was clearly resistant, showing resistance to the third line of therapy, or third TKI. Within a month, she went into a complete cytogenetic response range between 0.1 and 1, and within 2 months to 3 months, she already had a major molecular response. And at the end of 4th or 5th month in November, she was already in a 4 log reduction in a deep molecular response. By 6 months' time, she was again 0.00, more than 4.5 log reduction. And since April 2020, she is in a complete molecular response. So this is an amazing response, despite the patient was resistant to nilotinib and she had already failed 2 lines. So efficacy of asciminib is established if there are more than 2 TKIs failure, and this is approved now. In this case, patient was intolerant to imatinib and intolerant to resistance to 2 second-generation TKIs. That was dasatinib intolerant and nilotinib resistant. She has maintains a CMR and undetectable minimal residual disease at 4 years of follow-up. The side effect profile, there are no side effects of abdominal pain anymore. She's quality of life is excellent. She follows with me now every 4 to 6 months. And the improved compliance due to better side effect profile is certainly there. So what is the CML current status? There's a competitive ATV binding TKIs have dramatically improved the survival outcome. Some patients still develop resistance and intolerance to these drugs. Patients who develop treatment failures or intolerance have worst outcomes, as very well known. Then there are few remaining treatment options. So beyond second line therapy is really complex because there is a time period that you feel that this patient is probably not going to respond for a very long time, and you're looking at the younger patients, whether they will be going for transplantation. The TFR is not an option anymore in these kind of patients. And you also know the sequential use of TKI is associated with decreased probability of sustained durable response. So it is very important to have a drug that shows efficacy as a third line therapy. So in the unmet needs, of course, there is a new drug development, and then we have to revisit the third line therapy in case of failure of 2 lines, and the utilization of these TKIs with different mechanisms to achieve specific goals of progression-free survival and hopefully the overall survival. So these are tyrosine kinase inhibitors that are available, and asciminib is the newest one in this thing. They all have some sort of resistance and mutations involved with it. It has a different, because it's not a direct ATP competitive binding site. It occupies the myristoyl pocket and allostatically inhibits the TKI activation, not by a direct binding site like the previous TKI. So this is the first in class stamp which is known as specifically targeting the able myristoyl pocket inhibitor. And when you look at the response in the phase 1 trials, these are the non-T315I mutated patients. By 6 months or 12 months, if they are less than 2 prior TKIs, still showed an overall response and a specific major molecular response in 33 to 47% of patients by 6 months to 12 months. And if there were more than 2 prior TKIs, still 1/3 of the patients did have a benefit of achieving a major molecular response in these kind of resistant patients. Even patients who had used ponatinib, not for the T315, but for the non-T315, even in those kind of patients, there was almost 40% response of major molecular by 12 months. So let's look at this main trial, which is the assembled trial, which is a phase 3 trial. This was randomization of asciminib at 40 milligram twice daily against bosutinib 500 milligram once daily, which is a recommended dose for patients who have failed previous therapy. You can use 400 milligram, but that's for upfront chronic phase myeloid leukemia chronic phase, and bosutinib, as you know, is also approved as a first-line therapy also. So I guess the consideration for asciminib was because most of the patients usually go through a tyrosine kinase inhibitor that goes through imatinib, nilotinib, dasatinib, and then bosutinib. So bosutinib was selected because it has shown efficacy against the first-line therapy and it's already approved. When you look at the primary endpoint, which was a major molecular response at 24 weeks, showed a better outcome with asciminib, almost double the response to bosutinib. When you look at the MMR rates at weeks 24 and 48, and recently the updated, which was published in Leukemia, and we are part of this trial, King Faisal is part of this publication of the trial, shows consistent maintenance of major molecular response, which is almost more than double as compared to bosutinib on a follow-up, even in the longer follow-up of 96-week follow-up. When you look at the major MR4, which is a deeper molecular response of 4.5 log reduction, which is sometimes used in upfront therapy for consideration of TFR, it has maintained right from the week 24. It has maintained its week 96 with the major 4.5 and 4.5 reduction, almost double for the deep molecular response for asciminib. Again, presented in EHA recently as an abstract, shows that even if you have, for patients who are BCR level at the baseline of more than 10% compared to patients who had a BCR the baseline of less than 10%. In both these case scenarios, it has been able to maintain the efficacy almost more than double or 3 times asciminib as compared to bosutinib. So patients who were more resistant or less resistant, in both cases, it has shown an efficacy, which has been maintained over a long period of follow-up. And when you look at the event-free survival, certainly superior in asciminib, and this is one of the most important endpoints, secondary endpoints also. Maintained the proportion of patients who were event-free by 2 years was almost 57.4% for asciminib versus 25.2%, which is again more than double. And the median time to event was not reached with asciminib, but was 5.6 months with bosutinib. Looking at the subgroup analysis, in almost all of the cases in the subgroup analysis, this favored asciminib as compared to bosutinib, whether these are the age categories, the lack of efficacy, reason for discontinuation or intolerance, or the number of prior TKI therapies. In almost all cases, there seems to be a superiority for asciminib at follow-up of MMR at 96 weeks for the subgroup analysis. So it has maintained among all subgroups. And you look at the grade, one of the most important for any drug that is developed, or a new drug that shows an efficacy, one of the most important things that you want to look at is the adverse events. And when you look at the adverse events, that is in more than 20% of the patients in any arm, you can see that on almost all of the patients, the blue one is bosutinib, the green one is asciminib, has shown a better outcome as far as the adverse events are concerned. Especially diarrhea is very well known, but nausea and the rashes and the vomiting certainly reduced. And the patients that I have experienced who are part of the assembled trials, they're both doing almost have no side effects and tolerating the drug very well. The arterial-occlusive events, which is major issues with a lot of TKIs, especially the third generation ponatinib, and in the second generation nilotinib, and to some extent also dasatinib. The asciminib, when you look at the patients with events by week 24 cutoff, whether their myocardial ischemia is slightly up, but when you look at the acute coronary syndromes and as well as coronary artery disease, ischemic stroke, is almost equal or almost the same as bosutinib. The overall patients with arterial-occlusive events slightly higher is in asciminib as compared to bosutinib. When you look at from the patient's perspective, which is one of the most important for the quality of life, and the quality of life questionnaire that was submitted and patient present and submits it on every clinic follow-up. When you look at the patient-reported outcomes, nearly all of the outcomes are actually favors improve outcome for asciminib as compared to bosutinib. This is one of the most important things. Quality of life for somebody for a disease where the outcome is almost equal to overall survival is equal to a normal lifespan for general population. So what is the role of asciminib at the present time? It's approved as a third line. It has shown an excellent efficacy and minimal and improvement in this minimal toxicity compared to bosutinib, the second generation. So looks like with safety profile in the cardiovascular events also and other, this probably will overtake in other scenarios as a second line. But right now, the drug is approved as a third line. So if 2-line failures, this has shown benefit and efficacy compared to a second generation tyrosine kinase inhibitor. As far as the T315I is, the efficacy is established in the phase 1 and phase 2 trials. It is not yet, it is as a regular approval in Saudi Arabia by the Saudi FDA, but hopefully will get approved as for T315I also. And add on to improve deep molecular response, there is preliminary data. For the sake of the time, I did not present combination therapies or as an add-on to imatinib if the patient does not achieve a deep molecular response. And so far, most of the clinical data is actually promising, not only in the achievement of the deeper molecular response, but also the efficacy of tolerating the drug also. As a second line, there is no data yet, has not been approved. And as a frontline therapy, of course, it is not approved. So it is currently approved as a third line. Sorry, as a frontline, it is not approved. As a third line, it is an approved drug and has shown efficacy. So superiority in all aspects of improving major molecular response, event-free survival, along with minimal or low toxicity compared to bosutinib. Incorporation of asciminib as a third-line therapy is a safe and effective treatment option for patients who fail two-line therapies. It improves MMR and better event-free survival. When you have an improved MMR and a deeper molecular response, there is obviously avoiding of the transformation to an advanced phase disease. It is efficacy in reducing long-term toxicity, and of course, it is improved quality of life from the physician's perspective when you see these patients, and from the patient's perspective also. I think that's it. Thank you very much. If you have any question, I can answer.